All right, guys, this is going to be respiratory distress airway management. This is policy 8020, and we're going to spend a little extra time here because there are some things I want to get cemented into your brain that becomes automatic when you're taking care of someone who has respiratory distress. A couple of very important basic things to remember. There's a yin and a yang with our breathing. There's oxygenation and there's ventilation. So oxygenation is the process of moving oxygen from the atmosphere into our bloodstream in order to maintain metabolic processes down at the tissue level. Those metabolic processes have byproducts that they produce. One of them is an acid called CO2. And the process of moving that CO2 from the cellular level back to the lungs to be exhaled is called ventilation. So oxygenation and ventilation are the yin and the yang of the respiratory system. Both of them are important. Both of them can lead to respiratory distress and respiratory failure. That leads me to the next term. What is the difference between respiratory distress and respiratory failure? So some of the signs of respiratory distress include their respiratory rate. That's the simplest. Are they tachypnic? Are they breathing faster? Grunting, nasal flaring, retractions, sweating, wheezing, or even their body position, how they're sitting, can be a sign that they're in respiratory distress. We all have that picture of the COPDer that's tripoding, and you can see the nasal flaring, you can see the retractions, you can hear the wheezing. They're usually tachypnic. That person's in respiratory distress. There is a point, however, where they cross over into respiratory failure. It's important that we spend some time and we look at the individuals we're taking care of to see if they're heading toward respiratory failure. SaO2 is how we measure oxygenation. Ventilation is measured by end-tidal CO2. So it's just really important that we recognize the fact that there's a yin and a yang. There's oxygenation and ventilation. That's down at the cellular tissue level. We have ways to measure both, and our eyes are our best friends. All right. So now let's jump into the policy a little bit. So severe respiratory distress, all of these patients require immediate transport and early transport for everybody else. The policy does say that you can use a King tube or an i-gel as an advanced airway of choice on the first attempt. So the BLS side of things is giving them supplemental oxygen, watching out for trauma patients using jaw thrust. They're very simple things we can help someone in respiratory distress and even someone heading into respiratory failure that they may be not able to do, like clear their secretions using suction, remove foreign bodies. Airway adjuncts is something that often gets forgotten. So a nasopharyngeal airway is a best friend. Two of them are even better. So if you have someone that's becoming somnolent and you need to support their ventilation, starting with the BLS side of things is very important. Start BLS, work ALS, because a BLS maneuver that's used in the right way can often reverse or fix a problem. So nasopharyngeal airways, and if we need to, oropharyngeal airways. And then we can even assist ventilations as needed. How do we do that? We can use BVM. We can use CPAP, those things, okay? So, and yes, CPAP does assist ventilation as much as it does oxygenation, if not more ventilation than oxygenation. We can talk more about that if you'd like to when I'm with you. All right, so once we've done the BLS interventions, we're going to have to move to ALS. So all of these people are going to need vascular access, and we've all heard the mantra, GCS less than 8, intubate. Well, yes and no. So as I said above, sometimes just a BLS intervention will clear the problem. So make sure we're focusing on BLS, administering supplemental oxygen, using our nasopharyngeal airways, using our suction, positioning the patient correctly. All of those things can oftentimes alleviate things. You need to be just a little patient because it does take a little time to reverse the process. I think people panic and they don't get the response they want fast enough, and so that they go quickly through this whole process. Go through it step by step, slowly. All right, if they've got an overdose or they're hypoglycemic, we're going to use our Narcan and our dextrose. Anytime we place an advanced airway, that is a king tube or an I-gel or an endotracheal tube, anything advanced that goes into the airway requires waveform capnography. We want to use waveform capnography on all of these patients. We have to use it on all of these patients. I consider it borderline medical malpractice if you don't use it. Waveform capnography on all advanced airways. And then finally, the policy says 2 attempts can be made by a paramedic, and then if not, it needs to go to another paramedic. All right, the final page of this just has a flow chart for foreign body and epiglottitis and anaphylaxis and trauma. You can look through this yourself, but basically at the very bottom of this, transtracheal jet is a possibility if you cannot establish any airway, no matter what you've tried to do, including a backup plan. Okay, so that was a long 8-minute talk. If you need to listen to this again and go through it again, it is worthwhile. It's extremely important that you understand the importance of identifying respiratory distress when it converts to respiratory failure and what you're trying to improve in the care of the patient. All right, we'll see you on the next one.